the saying women cannot keep anything in their secret, anything in their abdomen. So it comes out to the umbilicus. So again, you can just remember that.
Welcome everybody. This is Simran Verma, second prof MBBS student, and today we have Dr. Rohan Nathwani, who is a surgery resident, and today's session is on the topic ventral hernia. Sir, please enlighten us.
Hello everyone. As Simran said, myself Dr. Rohan Nathwani, who is a surgery resident at present, and today we'll be dealing on a topic that's not that much common, but yeah, it's related to surgery. That's the ventral hernia. So going back to the presentation. So yeah, ventral hernia. So before we begin, I will just let you know what is hernia. So hernia is basically it's a protrusion of a hole or a part of viscous through the membrane, through the wall that contains it. So it's basically something which comes out, something that protrudes out your body. That's you can say with the content or with the wall which it contains it. So in case of ventral, what we are discussing today, we have ventral is basically in case of the anterior abdominal wall, whatever the hernia comes, we will discuss that only. So before going to the types of hernia, ventral hernia, I will just tell you what is hernia. What is the parts of hernia? So we have the mouth, we have the body, we have the fundus, and below the body we have the neck. So basically mouth, neck, body, and the fundus. So we'll just discuss what it is related to this. Moving on, what are the types of ventral hernia? So we have incisional hernia, epigastric hernia, umbilical and paraumbilicals. Both are synonymous these days, but yeah, we have that. Spigelian hernia, lumbar, parastomal, and traumatic hernia. Coming back, incisional hernia. So what is incision? As the name suggests, incision. There was some incision which was taken in the body. So from the scar, there is some protrusion. So yeah, the hernia protrusion through the scar due to some previous surgical operation or some artificial, that is some accidental trauma you had. So it causes that. So what are the risk factors? We have the infection of the wound and the injury during the surgery, that is the injury to the motor nerve, which will cause this hernia formation. So basically, it will start as a disruption of the musculofacial layer of the wound in the early post-op period, and slowly it will increase in size. And it can be prevented with a good surgical technique, as I've written here. But yeah, there are some patient factors also which we have to consider in this case. In case of patient factors, it's like after the surgery, the patient started moving on, like he has some heavy weight lifting or some constipation, cough, and all that he has. Basically, which will lead to increase in abdominal pressure, which will lead to this incisional hernia. And surgeon also, there are some faulty surgical techniques, or there are some faulty surgeons which can lead to this hernia with not proper technique and all that. Moving on, clinical features. It's a painless swelling. Painless swelling. There will be only discomfort and bulging which will come out of that incision, that is a scar mark. And sometimes there is dull ache and nausea, vomiting is in that case when there is obstruction. Because if there is obstruction, the stool or the fecal matter or the whatever you say bolus will not move forward. It will come out of the mouth. So it's nausea and vomiting. And it's as I said, it steadily increases with time, size increases. And in this case, there is very low risk of strangulation. So I'll just discuss what is strangulation. Strangulation is basically there will be a coming out of the hernia protrusion. The hernia protrusion will be having lack of blood supply. There will be necrosis and all that. I will just tell later on all that. But yeah, because of broad neck, we don't generally see a strangulation in case of the incisional hernias. There is a low risk. Coming on, see, this is a case which I saw in the emergency. And in this case, you can just see, I'll just start the video. You can see there is a protrusion while cuffing. The patient is cuffing and there is some protrusion to the incisional scar. The scar mark you can see. Basically, the patient had a lap chole or what cholecystectomy, where the scar mark is above the epigastric. There is an epigastric port which we generally do in case of lap chole. So through that, the protrusion is seen in this case. Coming to the epigastric hernia, epigastric is basically above the umbilicus. Anything above the umbilicus can be epigastric hernia. There are many differential diagnoses like lipoma and all that. But yeah, as a surgeon point of view, I'm just telling it's an epigastric hernia. It's basically it arises to the middle aspect, that is the linear alveoli, what we see as the anatomy, anywhere between the gyphoid and the umbilical, midway basically. It's a healthy man, basically in a common healthy man, and between 25 to 40 years. So yeah, then we have the epigastric hernia, which are usually less than 1 centimeter in maximum diameter, and it contains only extraperitoneal fat, which gradually enlarges. And rarely any bowel content will be there in case of epigastric hernia, but yeah, in case of large, only peritoneal sac will be there. Moving on. What are the clinical findings or the clinical features you see in epigastric hernia? We have the epigastric pain, which will mimic. We have the epigastritis, like the gastritis, and we have the swelling, vomiting, nausea, and it aggravates by eating. Because eating, there will be an increase in the abdominal pressure. It will aggravate the hernia. In that case, it aggravates and reclining on this relief. It relieves on reclining. Then strangulation. It will be there in every hernia. It is must be remembered that it is unlikely to be reducible because narrow neck. In case of incisional hernia, there was a broad neck I just discussed. In case of epigastric, we have a narrow neck, and the cuff impulse may or may not be felt in this condition. Because if it's not reducible, it will not come out during cuffing. So in that case, nothing will be done. Then swelling cannot be moved over the underlying structures, which rules out lipoma. Lipoma is a very common differential diagnosis in this condition. In lipomas, it is very movable, but in this case, it is not movable over the underlying structures. Coming to umbilical hernia is basically the hernia will be presenting to the umbilicus, that is related to the umbilicus, and we have the four varieties here. And see, first is the exomphalos. Exomphalos is basically abdominal content will come out to the umbilicus, but there will be transparent membrane. That is a diaphanous membrane in this case. So if there is no membrane and the abdominal contents come out, that's the gastrosis, like that. Coming to congenital umbilical hernia. Basically, it comes out through the that is umbilical scar, which is very weak in case of this condition. And it appears, you can see it in within few weeks of the birth, and it's often symptomless. So we will just wait till 5 years of age. Generally, before 5 years, we don't operate in any congenital umbilical hernia. Obsession strangulation is very uncommon in this condition. That too below the age of 3 years, you cannot see. See, in this case, you can see an infant with the umbilical hernia. There is a protrusion at the umbilical site. Moving to the acquired. Acquired is basically we have acquired during our lifetime, that is between old age. So it occurs in adult life and it's produced to the umbilical scar. Almost invariably, you can say due to the intra-abdominal rising pressure. That is due to anything. It can be pregnancy, ascites, bowel distension, ovarian cyst, or fibroid, anything which will lead to increase in intra-abdominal pressure. Coming to the diagnostic features, what you will see typically in this case, you will see a bulge in the center of the umbilical scar, which will evert the whole umbilicus. You have to see the age of the patient. It will be adult patient, easily reducible. It will be reducible and definite impulse. See, whatever hernia is reducible, there will be an impulse on crying, coughing. In case of children or adult, there will be an impulse. And size of the hernia will be varies, and the content is usually small intestine, so it will be resonant to percussion. So as I will discuss, there are two things like enterostele and omentostele. In case of enterostele, the hernia contains intestines, whereas in omentostele it contains omentum. So in omentum, when you percuss, it will be dull note, and in case of enterostele, it is a resonant, it resonant on percussion. And again, you will can hear the vowel sound as the intestine is there, and in omentostele, you cannot hear any vowel sound. Then this acquired condition, it won't go away like that. You have to operate it. There is no choice in the case of acquired condition. Then we come to the para-umbilical hernia. And para-umbilical hernia, it's the synonymous, but yeah, it's a common acquired also, you can say. And it's just adjacent to the umbilicus. Here in the picture also you can see it's not in the umbilicus, it's adjacent to the area. That is the usual site is between the two recti. Then what are diagnosis features in this case? It's a middle old age obese woman are commonly affected, and symptoms are pain and swelling. Surface is smooth and edge is distant. It contains momentum, that is looking firm, that is a duffy, you can say duffy or firm, same thing. And in case of bowel, it is soft. So umbilical hernia that includes bowel are prone to become irreducible, obstructed, strangulated, narrow neck. And same thing, narrow neck will cause more commonly cause strangulation. So as I said, see, you have to just remember, in epigastric hernia, it is the men. Men are more common in case of epigastric hernia, and whereas in para-umbilical or the umbilical hernia, we have the women. Because as per the saying, women cannot keep anything in their secret, anything in their abdomen. So it comes out to the umbilicus. So again, you can just remember like that in what I remember. Umbilicus is more common in men, and umbilical is more common in women, and epigastric is more common in men. So yeah, there's some video. See, you can see a video. It's a umbilical hernia. It's an adult acquired condition. So you can just see while cupping, the patient is there is a protrusion of the abdominal content or whatever it will be there. Coming to the Spigelian hernia. What is Spigelian hernia? Spigelian hernia is not very common, but it's very typical. When a patient comes to you with a Spigelian hernia, you will definitely tell it's a Spigelian hernia. There is no differential diagnosis or something like that in this condition. And before that, you have to know the anatomy in this case, because this hernia occurs to the linea semilunaris, that too at the level of arcuate line. So what is arcuate line? I will just tell you. Arcuate line is basically is the one third between the umbilicus and the pubis. You will just mark it out. It's a one third between umbilicus and pubis, where basically what happens is a demarcation. The internal oblique aponeurosis and the transverse abdominis aponeurosis comes up. So it's a demarcation. And what is linea semilunaris? It's because lateral edge, lateral end of the rectus abdominis muscle, which is basically you can say it's derived from the internal oblique aponeurosis. So yeah, in young patient they usually contain extraperitoneal fat only, but in older patient you can see a peritoneal sac as well, and it will become enlarged in indeed. So yeah, we have to operate in condition. We have no choice in this condition. Clinical features, what we have is it's a typical intermittent. You won't see a continuous pain in this, dull, intermittent, and diffuse pain. Older patients generally present with the reducible swelling at the edge of the rectus sheath. And incisors and strangulation is common, as I said, in every hernia mostly, with a narrow neck, not in the broad neck. Coming to the lumbar hernia. Lumbar hernia is basically it develops to the inferior or the superior lumbar triangle. So you have to remember the anatomy here again. It's in the back side. So we have the inferior lumbar triangle of the petit, which is bounded below by the crest of the ilium. Lateral we have the external oblique, and medial we have the latissimus dorsi. And less commonly it is to the superior lumbar triangle, but yeah, we have to remember. It's also very rare. We don't see generally. Parastomal, yeah, it's a parastomal is an acquired hernia because we are doing stomy in this condition. Anything. Because of anything, we are doing stomy in the abdomen, like ileostomy and generostomy, whatever stomy we do for the patient benefit. So here the muscle defect is created during the stoma only, and it tends to enlarge in size over the time, and ultimately massive herniation you will see around the stoma. So the rate of parastomal hernia is around 50%. So you can see in this bit that is a red thing that is a stoma which was seated, and the abdominal content you can see it's basically ileum or something which was there, and around it's a protrusion of the abdominal contents. That's the parastomal hernia. Then what we have is the chromatic hernia. Chromatic hernia basically it's in the non-anatomical defects because there is no defect as such in the body, but due to the now trauma or something like that, trauma it can be in this condition we have three types. First is the stab injury or the wound stab injury, which will cause incisional hernias, as I discussed in the starting only. Then we have the blunt trauma. After the blunt trauma, what happens? There is some tear in the abdominal muscles. So with tear and split, which will cause a defect and hernia and protrude to that. Then we have some traumatic denervation, that is a nerve injury during the trauma, which will lead to muscle atrophy. And during muscle atrophy, during time, what we see is abdominal muscle, abdominal bulging basically due to the atrophy. Then investigations we have is mostly we diagnose it clinically. We don't need investigation as such, but for the legal issues we have to do USG and CT scan these days. But yeah, clinical diagnosis is very important. It's a reducible, non-reducible, insulated, strangulated, and all that. Whatever features what I already said, it can we have to see that in-person cupping, crying, and all that. Then USG is a very definitive, and we can know what is the size of the defect in USG and how we'll operate. We can think about it because nowadays we do both laparoscopy also we do open we do robotic also is there, but I don't think in India we do robotic hernia actually. Laparoscopy hernia also in very higher centers we do. Then coming on CT scan, we only do when there is a doubt, there is no confirmative diagnosis is there, you cannot confirm, then only you do a CT scan. As such, there is no need. Coming to the treatment aspect, treatment in general, what I have given here is first is conservative, then is surgery. What we do, conservative is thrust. A thrust is basically it's a belt-like thing which applies the pressure to the site of the hernia. Basically, it will not allow the buzz to come out of the body, which will indeed prevent significant herniation as well as symptom will be reduced in that case. But it's a short term. We have to do surgery before so we can do this. Sedation can be done to reduce the pain and Trendelenburg position. That is basically you have to put your head down, leg up at around 16 degree. It will help. It is very helpful in case of obstruction. But yeah, we have to do surgery. There is no choice for that. And yeah, so in we have three types: herniatomy, herniorrhaphy, and hernioplasty. Herniatomy is basically done in children's where abdominal muscles have not been created or abdominal muscles are not formed till yet. So we can just remove the sac and just close the neck. And again, as the age advances, it the muscle will come and it will cause adherence will be there. So there is no need to put mesh or something like that. In herniorrhaphy, basically what we do herniatomy, that is the hernia sac we remove, and then we do the reconstruction. The abdominal wall, we have to make it very strong so that there is no recurrence again. In case of hernioplasty, what we do is we just put a mesh. In mesh repair, what we do in hernioplasty is decrease the recurrence rate, it decreases. So nowadays in adults we do hernioplasty only. Hernioplasty, it was a old concept, now we don't do. But yeah, it's a hernioplasty. Then specific treatment we will do. First, we have the strangulated hernia. And obstructive hernia, it's an emergency. As I said, it's have to be treated immediately. Obstructed, you can wait till the reports and all blood report, but strangulated, you have to take it to the OT very soon. It's an emergency. Then coming to incisional hernia. In seasonal hernia, we have to repair the whole incision which was taken in before surgery. So we have to repair the whole part. What we will do in this case, we'll approximate the musculofacial layers and with minimal tension, because if we give a maximum tension to that area, there's chances of recurrence and the patient will feel very much heavy in the abdomen. So we will give minimal tension, and mesh is very important, which will reduce the risk of recurrence. So the simplest approach is, yeah, simplest, we have the only mesh repair. And if there is the surgeons are very good at doing the hernia surgery, there is a micromuscular sublay repair. So in only mesh repair, what we do is that we just put it on the defect. We just put the mesh on the defect itself. And in case of retromuscular sublay repair, we'll put the mesh below the rectus abdominis muscle, which is very much convenient for the patient as there is much less post-op complications. But generally, what we do is only mesh repair because not everyone is an expert in everything. Coming on, yeah, in that case again, if there is an open wound or infection where it's a contraindication for surgery, we don't do, because the infection will go inside the abdomen, which can cause peritonitis. It's again an emergency, so we don't do it. Again, in case of epigastric hernia, if it is a very small, we don't do anything. It will disappear spontaneously because of the infarction of the fat. But if it's a small to moderate size hernia, that too without a peritoneal sac, we don't do anything in that case also. But yeah, surgery should be done in case the hernia is very much symptomatic condition is there. Then the defect in the linea alba, what we close in this condition, the epigastric hernia, we have to close it with non-absorbable suture in case of adults, whereas absorbable suture in case of children. Coming back to umbilical hernia, as I said, only observation has to be done, as 95% it will close by itself till 5 years of age. Then depending on the size, we'll operate the patient. See, if it's greater than 2.5 centimeter and the age of the patient is 4 to 5 years, we have to fix it surgically. So yeah, what I was telling, less than 1 centimeter, we have to, there's a technique that is the simple figure of 8 suture, or you can repair by a Dan technique. And if it's up to 2 centimeter, you can have to suture it with a minimal tension. And if it's greater than 2 centimeter, we have to use a mesh. There is no choice for that. So yeah, there are two operative modalities. The photos you can see here is, one is the open technique. That is open. We have to open the openly inside and all that we do, reduce the content, and then the close the sac and all that. And we have a laparoscopic defect. That we have to, on the right side you can see the laparoscopic view. In laparoscopy we are very advanced these days. We use it laparoscopy, but that is used in higher centers. Laparoscopy is somewhat difficult in case of hernia than any lap chole or something like that. So yeah, specifically in hernia, coming to, it's we don't do too much in this. We just take a transverse incision, that too on the sac, and we just cut the neck and approximate the internal oblique and transverse abdominis. That is what we do. There is no mesh and all that we don't do here. Lumbar also, what we do is there is a mesh repair is very much recommended in this case because it's very difficult to close. Parastomal, ideally, what we do in parastomal, we have to anastomal bowel. We have to put inside the whatever stomy and we have to anastomus, but generally it is not possible because there was some etiology which we have, which we had lead to stomy, so we cannot do that. So in this case, we can recite the stoma in anywhere in any area in the abdomen. So yeah, we can do that. And mesh, here we can put a mesh which are best placed in the retromuscular space. Coming back, traumatic hernia. Traumatic hernia is very much, if it's very symptomatic, or if investigations show there is a narrow neck, then only we will go for any surgery because there are high risk of obstruction and strangulation. If it's a stab wound, traumatic hernia, which are straightforward to repair using we can do open as well as laparoscopy. And yeah, robotic we have tried, not in India as such, I don't think so, but yeah, in foreign country robotic you have tried. In India, we only have open and laparoscopic techniques. So yeah, thank you so much.
Thank you so much, sir, for an incredible session. Now, I would like to put up some questions regarding ventral hernia.
Yeah, sure.
The first question, is it necessary to lose weight before an incisional hernia repair surgery?
So in case of incisional hernia or any hernia, we have to lose weight if there is a patient is obese, that is more than 25. If the patient is obese, BMI, we have to get it between 18.9 to 24.5. What is the criteria we have recently? So we have to put it in the BMI range. So why? We do it because there are some post-op complications in case of obesity, and as well as not just post-op complication. If we do a laparoscopy, we have to use a different instrument in this case. So we generally tell the patient to reduce the obesity. It's for the betterment of the patient itself, so less complication will be there.
Okay, sir. So, what are the possible risk factors of abdominal hernias?
So yeah, in case of abdominal hernia, anything which will lead to increase the inter-abdominal pressure will lead to abdominal hernia. So we have like constipation, which where we strain so much. We have the asthma patient or COPD patient where we cough, and then there are some again like pregnancy and polyp and all that which will increase the pressure. And other than that, we have some genetic factors. We have the men are more common, family history, genetic factors. And other some smoking history is there because it's very important, because smoking decreases the collagen metabolism, and there is some defect because of collagen metabolism, and it will lead to the hernia. So that's it.
So, what could be the possible complications of incisional hernias?
In case of incisional hernia or any type of hernia, the complications what we find is first it can got irreducible. The neck becomes narrow. So as I just today I didn't mention that, but yeah, that's it. Because most common is the adhesion. Because of adhesions, the neck become narrow in many hernias, and because of narrowing of the neck, we will lead to irreducibility. Then we can move on to obstruction. Then move on to insertion or obstruction are more or less same only. And then at last we can go for strangulation, which is an emergency.
Okay, sir. So, during the session, you used the terms incarceration and strangulation. What is the difference between an incarcerated hernia and a strangulated hernia?
See, in both this condition, the neck is narrow, and in this case, the bowel or omentum, whatever is the abdominal content which is protected inside the sac, will be present there only. It cannot be reduced back. So basically, it's an irreducible condition. And in case of obstruction or incisation is the same thing. It is got obstructed. It cannot move behind. It is not reducible in that case. So what happens in that case, if something is not moving inside? So what happens if there's a bowel present in that area? So it's not moving inside. There's a bowel obstruction will be there. So the patient main complaint will be is the lack of he cannot take food. Vomiting will be there. There is no defecation, no constipation issue will be there in that case. But as such, the patient is stable. There is no only tenderness or severe pain will be there. But in case of strangulation, the problem is there is necrosis of the bowel, necrosis of the omentum bowel, whatever it is present, because of lack of blood supply. The lack of blood supply is basically due to the venous congestion. Veins will be the blood supply with the vein what will be there in there will congested and causing the artery blockage will be there, which will lead to infection and all that WBC and all that will be inflammation will be there. So the patient here will complain of shock, severe shock with the face only. You can just tell the patient is having strangulation. We have hypotension and all that, severe tenderness, pain and all that will be there. So there will necrosis basically. So we will operate what operation is also very much different. In case of obstruction, we'll just reduce it. We'll try to reduce it, and if it goes, it's okay. And in case of strangulation, we have to cut an anastomosis of the dead part, the live part, I say.
Okay, sir. What are the properties of an ideal mesh that shall be used for a hernia repair?
Ideally, it should be a basically patient friendly mesh. That is, it should be inert. There should be no harm to the patient after the operation. It should be very much stable. There's the least recurrence will be the recurrence should not be there, but yeah, it happens. But yeah, so it's mechanically stable. It's inert. It should be inert, non-allergic. It should not cause any allergy to the patient. Non-carcinogenic. There should not be any carcinogenic reaction further. So and that too in India, in India and all, we have to think it is very cheap. So it should be cheap also.
So we're done with the questions. Thank you so much, sir.
Yeah, thank you again.